Good morning, everybody. So, after the banquet, as usual, attendance is poor. But yes, the conference should go on. So, I request Anagha to start her first presentation.
Yes, sir.
And she is going to speak to us on the cataract in RK. Dr. Anagha.
Yes, sir. Very good morning to all of you. At the outset, I'd like to thank team APOS and AIOS for giving me this opportunity. So I'll be speaking on optimizing outcomes in post-RK cataract surgery. So those patients who have undergone any kind of keratorefractive procedures, especially RK, are a totally different subset of patients. They have already undergone a refractive surgery because they don't want glasses. So they're highly demanding, and decision making in these patients could be really tricky. So the basic challenges are the optical biometry it is different, the IOL formulae that you would use is different, and hence that results in a different postoperative refraction, which can cause a refractive surprise. So these are the challenges which we really need to face. There are also issues of visual quality like higher order aberrations and irregular astigmatism because of the RK marks, and some people also have issues of dry eyes. The most important measurement is the keratometry, which getting reliable measurements in these patients sometimes can get a little tricky. So we have various methods of measurement, whether it's the auto-K, the optical biometry, corneal topography, and also doing a pentacam in these patients is absolutely mandatory, so that you rule out how much is the amount of irregular astigmatism, how much is the higher order aberrations on the corneal wavefront, and give a proper guided visual prognosis to the patient. So closer you go to the center, it's more accurate, and we also need to use multiple equipments and correlate the readings. Also we do keratometry at different times of the day, at least 2 to 3 times, and we are sure, make it sure that you're getting consistent and reproducible readings so that the biometry is as accurate as possible. In spite of that, you can have fallacies. That is because there is overestimation of the keratometric reading from the from the paracentral region. So what happens is you are ignoring the flatter central region, causing underestimation of the IOL power, causing a hyperopic outcome. So very typically you get a plus number refractive surprise in the postoperative period. Especially in RK, because of the RK cuts which are deep, it affects both the anterior as well as the posterior curvatures, causing a central smaller optical zone. So there is a very great variation in the corneal power from the center towards the periphery. Also, a falsely shallow ELP is predicted because of this, and the formula itself recommends a lower IOL power. So, and 1 mm of error in ELP corresponds to almost 1.5 diopter change in the final refraction. So there was this PERC study which showed that there's almost a 43% hyperopic shift in their 10-year data. There's diurnal fluctuation also in these patients. So when you do the test in the morning, you may have a cornea which is swollen, which is more hyperopic, and over the course of the day, they undergo a myopic shift. And that is why doing it different times of the day is important. You also can have postoperative transient hyperopia because of stromal edema at the incisions. Also, there is a long-term hyperopic drift, and that is why it's better to target myopia in these patients. Especially if there are more incisions, it's better to target a little higher myopia so as to get a good visual outcome. Always when you take an incision, it's better, if there are too many incisions, it's better to take a scleral incision, or if there are lesser incisions, do not go over the incisions, try to take incisions between the two RK cuts. Whether or not to use premium IOLs is controversial. However, if the astigmatism is fairly regular, you can use toric IOLs to debulk the astigmatism, but remember that the higher order aberrations will be high and quality of vision will be poor. Multifocal IOLs definitely, because of the irregular astigmatism and irregular corneas, have to be used only with caution and best avoided in these patients. Counseling needs to be done regarding not only night vision issues but also the chances of residual refractive error in spite of all the precautions that we are taking, and the possible need for correction in the postoperative period. So let's look at a few examples. So this was a patient who had undergone an 8 incision RK, and you can see that there is a cylindrical number in both the eyes, in the astigmatism, and the higher order aberrations, as you can see on the corneal wavefront. So here we use the ASCRS post-RK calculator. So for the right eye and the left eye, what it does is it gives you multiple IOL formulae, and it gives you the average, the minimum, and the maximum IOL power that you can put. So in the right eye, what we did was we used a 17.5, and in the left eye also we used a 17.5, and we planned an IOL for this patient. One more thing we can do is you can use the Atlas corneal topographer, and for these prior RK patients, you have an option of putting the 1, 2, 3 and 4 millimeter ring values. So the more data you enter, the more accuracy you can get in the IOL power calculation. Using an EKR report also helps in understanding how much is the keratometric variability. For example, if the base of the graph in the left, you can see there is this blue graph. So if it's a very spread out graph and the base is very high, very long, then you know that there is a lot of keratometric variability in these patients. We have also used toric IOL in these patients, so just be aware that rest of the procedures will be the same, but we need to take special precautions in these patients. Now this patient underwent a toric IOL, and look at the immediate post-op result. He had almost plus 2.5, plus 2.75 in both the eyes. All you need to do is just wait and observe the patient, and within the next 3 to 4 weeks, the spherical component reduced. So this was a transient hyperopia, and which settled down with time. So the rule of twos is you need to plan for an IOL exchange or a piggyback, at least if 2 consecutive refractions 2 weeks apart are stable. Now we have advances in IOL power calculation. You need, like we showed, ASCRS online calculators, the Barrett's TrueK with TK, and the intraoperative aberrometry. Remember, these post-RK patients are different from the post-LASIK patients, and the same formula cannot be used for both these subset of patients. Even when we are choosing the ASCRS online calculator, be sure that you have chosen the prior RK, because you have different forms for the myopic LASIK, hyperopic LASIK, and prior RK. Literature has shown that the use of Barrett's TrueK as well as TK has been useful in improving accuracy. So this was another patient who had 12 cut RK 22 years ago, and you can see the topography, which is very typical, that flower petal appearance. This was the EKR report, and we used a toric IOL in this patient. Again, you can see that the maximum was 7.11, we used a 7.5, and here you can see that we were able to have a good result in 6/9 unaided in the post-operative period. This was another patient, 47-year-old, 4 cut RK only, but he was very demanding. He said that he wanted a trifocal IOL. In spite of explaining to him the guarded visual prognosis and all the risks, he insisted on it and was ready to accept whatever was the result. To our pleasant surprise, we saw the EKR report had a very tall peak, which meant that there was very less keratometric variability. So we went ahead and did the same calculation, and the patient did really well in the post-operative period. So basically, you need to evaluate case-by-case basis and only then take a decision. This was a very interesting patient, a very flat K, 27-28, one of the flattest Ks I've ever seen. And similarly, we kept a hyperopia of almost 1.5, a myopic target of almost 1.5 diopters. And remember, these patients, so she had a lot of cuts, so there was no place where you could have taken an incision at all. Ideally, I should have taken a corneal scleral incision, but still I went ahead, and you can see that this was the result. So these incisions can open up during surgery, and they need to be sutured. So this was the result post-op, and this is the last case, just 10 seconds. This was a one-eyed patient where both RK as well as LASIK was done. 18 cut RK and then LASIK also done, and the other eye was lost due to RD. So you can see in the interface there were a lot of deposits as well as RK marks. This was the topography and a lot of keratometric variability. So in these patients now, whether to choose a post-LASIK formula or to choose a post-RK formula was the question. There was a difference of almost 3 diopters in both the formulae. So we chose the higher power so as to get a good outcome. Even the OCT cornea shows a lot of deposits in the interface, and we went ahead with the surgery. The patient did well in the post-operative period. So to conclude, we don't need to really depend on previous data. Decision making can be difficult in these patients. we have various options of calculation, and counseling is very important in these patients to get excellent results. Thank you
Uh,
so much.
Thank you. I think Anagha, you did very well, and you covered every point. Thank you very much. In RK, see the previous refraction is not possible because RK was done some 25 years before, and so now what she says is very true. And in RK, you may have the 8 incision, 12 incision, 18 incision, 24 incision. So there are so many incisions in that, and the space required for the, you can say, opening may not be there. So you may get the opening of the RK, what she did is a sutured. But that only one thing happens, that that area where it is a weakened area never goes to the normal level cornea. So there that cornea becomes the, you can say, weak cornea. And whenever you are calculating, she has given very correct formula, but also you should see now there are the posterior topographer. So you can say the posterior surface of the cornea topography, that also helps you to calculate the, you can say, IOL power. A really very good presentation, and
I think most of the time when there are over 8 incisions and there's no space, you should go a little scleral.
Yeah,
Cut the
that's
guy
her
and go
case.
scleral and go into the go a little into the
Scleral,
and
yes.
then because you find that these incisions will invariably open up if there are 16, 32 incisions. The other thing you have to be careful is that many of these patients have these cuts going even into the pupillary area, and therefore the calculations go haywire completely. And therefore you should warn the patient, because these patients are refractive surgery patients, that they want that even after surgery their refraction should be almost zero, which you should always warn them that you can hit off very, I mean, you can be much off the zero mark in these patients. So I think we have to keep them in the patients have to be counseled that we are doing this more for your vision than than correcting your refractive error to zero.
Thank you.
Next speaker is Dr. Lahane, and he is going to speak on my experiences in pediatric cataract surgery. Dr. Lahane, please.
thank you, Sarab sir, Tushar, Agini, Anaga, and my friends. Uh, see, this is the my experience. We operate near about 550 pediatric cataract every year, and what I see when the patients are referred, and accordingly I have made a general this presentation, because this is not in the pediatric group. So as usual, there is no any financial interest, but if you see the uh, accounts of the pediatric blindness, and in that you can say 7.4% to the 15.3% of the pediatric blindness is because of the pediatric cataract, and this we should reduce the blindness. The secondly, the refractive error, as you know, that also causes the 33% of the blindness in the pediatric patients. Now see, when to operate? See, the bilateral dense cataract, early surgery at the 8 weeks or is to prevent the development of the, you can say, stimulus deprivation, amblyopia, and the second eye is operated within 1 week. See, people are operating the both eyes on the same day for the amblyopia, but I am of the opinion that it should not be done. If the infection happens, then that patient is blind throughout the life. The second is unilateral dense cataract. The urgent surgery is advised because already other eye is working, and the best done is 6 to 4 weeks, 4 to 6 weeks. We'll have to operate the case. Now, whenever you are operating, everybody is a cataract surgeon, and so they feel that yes, they can operate the pediatric cataract also. But if you see, there are few things which are different from the normal cataract, and those few things are, can say, smaller anterior chamber depth. Depth is smaller, cornea are steeper, then the shorter axial length, and the lower corneal and scleral rigidity is very low. So that is what is there. The second thing is also the Well-formed vitreous is thicker one, well-formed one. Soft lens, okay, thank you, thank you. The soft lens is very soft and the other is very elastic anticapsule. Whenever you are doing the rexis, in that it is very difficult to always better to go with the foreship. Now IOL power calculation, so the children 2 years, see do biometry and undercorrect by 20. So this is what we do, and then the children with 2 to 8 years undercorrect by 10%. So the now see the intumescent cataract, just I am showing you. The patient has came with the intumescent cataract and you will see I am doing the rexis. So what happens when patient comes to you after the 6 weeks? See, it is a fibrosed area, see here. So totally fibrosis whenever this see here, and also you can see the fluid is coming. So that is not helping me for the rexis. So now the AC maintainer I always use, and with the AC maintainer, so just an aspiration I am doing. So nothing is required here. So I can aspirate, and now after this I can see this as a it was stained. So the rexis is done. So basic thing is rexis in the pediatric cases is very difficult. And so now I am aspirating. You can see this is a aspirator that we have made in 96, just an aspirator. So you can see we are aspirating here, and on the other side also. So this aspiration doesn't require a large incision like a Cinco. And then you can see the rexis, it should be a slightly large rexis. Now I am doing the PCCC. So the PCCC normally can be done by the foreship, or even you can do the vitrectomy, and vitrector also can be used to extend the PCCC sometimes if it is not possible. So now you can see the PCCC here, you can see here the PCCC, and now see by the foreship I am extending the PCCC. It should be large PCCC, otherwise again there is a phimosis of this PCCC and patient will be unable to see. So in the pediatric cases, we do the PCCC up to 5 to 6 years of age. Otherwise, from 1 month afterwards, you will see the posterior capsular opacification, and to avoid that, we do the PCCC, and here you will have to do the multiple catch. It is not that one place like that you can do, because the posterior capsule is also same elastic like the anterior capsule. So I have completed this, and then we will do the vitrectomy and go ahead. So sometimes what happens, there is a ROP, and you can see this is a calcified cataract. When the ROP is there, and then the calcified cataract, so here then we again stain, and after that I am trying to do you can see the opening in the capsule. See this now, I am just trying to do the opening here, but because of the total fibrosis you can see here. So the capsule is going here, see here. I am trying to go on my left side and capsule is going on my right side. So this is because the elasticity and also the fibrosis of the capsule, and this is you can say in the ROP you get such type of cataract. See here, I am trying to do it by the foreship, and it is always that you should go gradually, and you should now see after that also there is a tag here. Can you see this is a tag? So that tag now, if you will now just pull that tag, then there may be you can say the subluxation type or zonular dialysis will be there. So what I do in such tag, if it remains, I do use it vitrector. See this now, and by the vitrector I cut the tag. So this tag is cut by the vitrector, and once it is cut, then I go for the PCCC. So here you will see the PCCC again here. Now see this. So whenever you are doing a PCCC, I use the foreship, and in the foreship I try to do near about the 3.5 the millimeter PCCC here diameter, and then you can see the vitrectomy, and once you can see this is the PCCC, large opening you should see, and then you can go ahead and do this. Now in the traumatic pediatric cataract, see here, see this is the traumatic cataract. In the traumatic cataract also again the rhexis is difficult. I am showing those cases where it is difficult to do the rhexis, and also see this, the results you will have to give good results because their age is near about the 70 to 80 years. When you consider our senile cataract, the age is 60 years, and here it is 70 years that is going to be there. And so we will have to see. Now I am doing the polishing, and after polishing also you can see because of the trauma. So there is a PCO. So what I am doing is I am just cutting. Here I am using the cutter for the posterior rhexis or PCCC, you can see here, and the cutter I can extend the rhexis, whatever because this is all fibrosis, see here. So I am 360 degree, I am cutting gradually and extending for the PCCC. So this PCCC can be done, and I can extend it, see here, I am extending, and once it is extended, then I can put a lens. You have seen the lens is implanted and the cataract is taken care. So in the conclusion, the pediatric cataract is a preventable blindness, but we should not make that in these cases it should be a permanent blindness. That is very important. Now the meticulous preoperative workup, anti-vitrectomy with PCCC in all children, the age is less than 5. I will calculation by repeated measurements from the experienced ophthalmologist, minimum 3, or otherwise you can give GA and then also you can calculate. And case follow-up is very important because here the amblyopia management also important. Thank you very much. Thank you, Namrata, and thank you, Andhra Pradesh Ophthalmic Association. Thank you.
Thank you. Thank you, Dr. Lahane, for an excellent presentation. As we all know that the capsular rhexis is the most important thing. Both the anterior and the posterior capsular rhexis are difficult to perform in these cases. And if once you achieve that, then things are easy in pediatric cataract. So he's explained this very well. He's shown the very good videos to be able to do a good rhexis even in a traumatic cataract. And an excellent presentation, Dr. Lahane.
And Dr. Ragini Parekh, now she is going to speak to us on the whenever you are doing the phaco, so and you come across the complication. So you learn from your mistakes. So after doing the 85,000 cataract surgery, she is just telling us the experience, learn from the mistake. Dr. Ragini Parekh.
Thank you, sir. Respected Padma Bhushan, Dr. Naushir Shroff, sir, Padma Shri Dr. Lahane, sir, Tushar Agarwal, sir, Dr. Harvansh Lal, sir, who is the president of AIOS, all my senior teachers and friends. And I would like to acknowledge the presence of one boy who is like a son to me. His name is Vikram. All the facilities that you see on behalf of the company, he makes a lot of effort to do this. So Vikram, I'm really proud of all the work that you do for these conferences. So what are the mistakes that can happen and what could have been changed? Mature white intumescent cataract, black cataract, posterior polar cataract, all these cases can create trouble. So as you can see over here, this is a white cataract. The capsule has been stained and a capsulotomy is being done, so which is very important, and the stain really helps. A small capsulotomy has been done so that in case there is a problem. As we were discussing in the previous session, that this is a direct chop and you can either trench or do a chop. So patience is very, very important over here, and as you can see over here, we are trying to do phacoemulsification and aspirating the pieces. A little bit of haste at any given time can cause problems. This is the last piece and one has to be very careful during this time. But if that does not occur, then what can happen is that now we are using the single port aspiration cannula and the AC maintainer to remove the cortex. 360 degrees of cortex removal is possible. You are finishing it and you are very happy that in a mature cataract phaco has been done. And now can you see this? We are trying to remove this, the cortex under the instrument, and you can see a PC tear. So instead of that, what could have been done is another port could have been used instead of this. So you can see a PC tear, and now what is to be done? You take a small micro forceps, put viscoelastic, and convert this PC tear into a PCC. So this patient, that is a PCC. Jaffe, when I was reading it as a student, always mentioned that it is not the loss of vitreous, but where vitreous is not supposed to be. And the IOL was put inside the bag. This is a second case where you are doing a phacoemulsification, and you start with the trenching and do the second division, remove all the pieces. This is the cortical matter remaining with the AC maintainer, as we always do. You remove it, 360-degree cortical cleanup is possible. You have to be very careful. Sometimes we've had problems. Now you are putting in the intraocular lens. Everything is very good. The lens is going in under BSS. There's nothing untoward that has happened, but as you can see over here, there is a PC tear. Sometimes there is a small pre-existing defect or the stretching of the bag. So if you recap this again, you don't seem to have created any problem or a mistake in doing this surgery. The IOL delivery was smooth. There was no haptic which was creating a problem, but there was a PC tear. And so, you know, sometimes if anything has to go wrong, it will go wrong. This is the third patient in which you are not able to do phacoemulsification. The exposure of the needle is more than that is required. It should be much less. But there is no phacoemulsification happening. There is no power. And as you can see, that the needle had chipped off, and that is why there was no transmission of power. This is another case where phacoemulsification is being done. You do the first division in a standard stop and chop, or you can use two techniques combined, and you can see here that the chamber is not very stable and you are not very comfortable. But you can see one thing is that a small, either the chopper or something has caused an injury to the sleeve and there is a leak. Fluidics are very, very important in phaco, and since that was not correct, there is a PC tear. There's a piece of nucleus remaining. Vitrectomy is being done. The tunnel is extended because I think that time that was the wisest thing to do. Convert it to SICS, because otherwise this nuclear piece would have gone inside and then we would have needed a posterior segment and a retina surgeon. So sometimes whenever there is a problem, you have to take a decision in the best interest, because complications do occur, but they have to be managed well in the interest of the patient. Sometimes you have to leave the surgery if the nucleus is already in the vitreous. Here the IOL is being placed. Ideally, it should have been a 3-piece IOL, but there must have been some support and a proper vitrectomy. So all surgeons, I was very hesitant to learn anterior automated vitrectomy, but it's very, very important to learn it if you can learn a cataract. Now you can see this is a posterior polar cataract, and we are trying to enter through the main incision. It can cause a unstable anterior chamber, and there may be small defects which may enlarge. So you have to be very, very cautious in these type of patients, because they have a small defect, and as you are cleaning the cortex, these defects enlarge. Even when they are not seen on slit lamp, these defects do exist, and again a proper vitrectomy is important. These patients are very, very young, and you cannot leave a mess behind. Of course, you cannot leave a mess behind in any patient, but PPC are very difficult cataracts to manage with regards to PC tear, and the likelihood of PC tear is very, very high, so one must be prepared for all eventualities. As you can see over here, this is another case where phacoemulsification is being done, and you are making the first division. See, the main thing is that anything can go wrong at any stage, even though when you feel. Sometimes at the end of the case, when you are doing hydration of the ports, there may be a descemet tear. So you have to be very, very careful. And you know, from the beginning only, if you are not able to achieve finesse, or there is no rotation of the nucleus, then you might doubt that there is something cooking which is not correct. You can come out, put some viscoelastic, reassess the situation, and then you can. Now here the followability. The nucleus is not getting engaged, and there is complete pupillary dilatation. There may be some iris diaphragm movement. So you have to be very careful. You have to assess the situation, because this case should have gone on very peacefully with the first division, and the pupil was dilated. Now it is constricted. So as we have noticed, and so you have to be very careful. The patient's eye is very important. It's a delicate organ. We are working within 2 millimeters. I have just a few seconds left. So you can lift the nucleus with the chopper and manage it. You can come out, use viscoelastic and mobilize the nuclear fragments too. So lots of things are possible. Reassessing the situation and then doing it is extremely important in any case where there are complications or complications are likely to occur, or in any case which is not going your way. Thank you, the AIOC and Harbanslal sir, Namrata, Santosh for a wonderful conference, and Andhra Pradesh Shea Society for hosting such a wonderful conference. Thank you so much.
Thank you, Dr. Ragini. I just wanted to ask you, you always use an AC maintainer, never bimanual irrigation aspiration. You don't do that at all?
No, sir, I don't do that at all. I have somehow or the other, we ended up doing a lot of cases always, and it is very easy to use the AC maintainer and the single port aspiration cannula, which is modified by Lahane sir, give it for autoclaving rather than change it every time in the phaco tubing and all that. So I've been trained to use the AC maintainer and the manual aspiration cannula, and I'm very comfortable with it.
Is the flow better? You find the flow is better?
So it can be, the flow can be managed. That's the best part about it. The bottle height can adjust the flow. Sometimes if you want it little more or less, it can be easily done by the bottle height. Also you have the regulator on the IV set which helps to regulate the flow, and it is very comfortable to use. It is very easy to use. There is no learning curve, and it allows, by changing the ports, complete 360-degree cortical cleanup. So I've been very comfortable with it.
Thank you.
Thank you, sir.
So now I will call upon Dr. Harbanslal, President of AIOS, and who started the live surgery first time again in AIOS. So congratulations, Harbans. And then the Harbans is going to speak to us on the IOL selection, that may be a multifocal, EDAP, or a premium monofocal. So Dr. Harbanslal.
Good morning, Padam Shri Professor Lahane, Padam Shri Dr. Naushe Sharaf, Professor Agni Parekh, and Professor Tushar Agarwal, and dear friends. We all know that now there are so many types of IOLs available, and what patient wants a full range of vision from 33 centimeter to infinity, and that can be achieved with the modern available IOLs. But there are certain limitations. Any ocular pathology, because these lenses cause some loss of contrast, whether in a dry eye, watery eye, corneal problem, vitreous problem, retina, macula, optic nerve, brain, any issues with the eye, patient may have a suboptimal outcome. There are photic phenomena associated with them, glare and halos. There is a loss of contrast, cost is involved, and any surgeon, explant is not so uncommon in these cases. Any surgeon who is putting the IOL must know how to explant the IOL. And selection of IOL power depends upon the financial status of the patient and what patient actually needs. So any patient for distance vision, if his refractive error is more than -1 or more than +0.5, is not going to be happy with his distance vision. Intermediate vision is equivalent to the -1.25 or -1.75 power patient has got. He can see the laptop, mobile very well. And intermediate vision has become very, very important, even in the not so well educated patients. Like once I asked a lady that whether his son, whether she uses any mobile, laptop or reading, ऐसा नहीं, डॉक्टर साहब कुछ पढ़ना वढ़ना तो होता नहीं है, हाँ लेकिन सारा दिन कैंडी क्रश यूज खेलते रहते हैं. So that means still those who are not highly educated may be using mobile a lot. So the intermediate vision is now more important than the near vision, because the reading habits have gone down. We are more onto the mobile, laptop and television. So another very important part the central part of all the IOLs in a multifocal ADOF lens, what we call as a bullseye, and this may have a distance vision, power for the distance, it may have for intermediate, or it may have for near, so that we need to know, because that will decide what patient wants and which IOL to choose. Majority of the lenses are, the central part is for distance, but PanOptic's central part is for 60 centimeter, and many of the Indian lenses have got this central part for the near vision. So you need to know which lens you are using. And then if we see the range of vision which is available, can I have a pointer please? Pointer. So if you see the lens, I am taking some prototype of lenses. A lens like Synergy, which gives you excellent vision at a 33 centimeter full EDOF. So from 0 to 33 centimeter, that means equivalent to -3 refractive error of the patient. Then there is a Symphony of Vivity, which gives you around 1.5, 1.75 addition effect. That means it covers the distance and near. And then the premium monofocal, which has got an addition of 0.5 to 0.075. That means if it is emmetropic, patient can see up to 150 centimeter, 1.5 meter distance, everything very clearly. And the monofocal, which has got a minimal depth of focus. Why I am talking about it, how to manipulate your lenses for the best and optimum effect what patient needs. So let's say if you are using a lens which is a trifocal with a Synergy type of a lens, if patient becomes minus, then what happens to him? If it becomes minus, his reading distance from 33 centimeter may become the 25 centimeter, which may be very, very uncomfortable for the patient, and the distance vision will not be clear. At the same time, if it becomes say plus 0.25, because of the EDOF, his distance vision, it will still remain very clear, and his reading distance from 33, it may become 40 centimeter or 37 centimeter, which may be comfortable. So that means when you are using a high power lens, we do not target myopia. While on the other hand, if you are targeting, looking at a Symphony type, Vivity type of a lens, so if there is a 0 for distance, he can see the laptop, mobile very well, but cannot read so well. So that means these patients, if they want to have a good near vision and intermediate vision, that means the first eye we can leave -0.25, another eye we can make -0.75. That means in these patients we target little minus, in fact, not on the plus side. And same way when we talk of the premium monofocal, and if the patient wants a perfect distance vision, treat these lenses like Synergy. That means even if these patients have got a plus 0.5, 0.75 addition, a patient becomes plus 0.25, there is no problem, he can still see 6, but he will not be able to see near. But if you want to give an intermediate vision to the patient, then you use them like a Vivity and Symphony. That means you make them little bit of minus 0.25, -0.75, he'll be able to read the mobile. So what patient wants and which lens you are using and what you should target your refraction is very, very crucial to make the patients happy and satisfied. On the other hand, monofocal, if you want to give the mini monofocal, you can do it. If patient wants the mobile intermediate, you can target one eye -0.5, another eye around -1, -1.25. But if patient says, I don't mind using reading glasses, then make him perfect for the distance, don't worry about the near at all. And we need to know that many of the monofocal patients can have excellent vision for near as well and for mobile. If the pupil size is very small, 1 millimeter, 1.5 millimeter, actually the multifocal lenses are not required. He will get a depth of focus even without any other lens. And the astigmatism, particularly if the minus cylinder is 90 degrees, these patients have a very good, excellent reading vision without multifocal lenses. Higher order aberrations, when you correct them, actually they reduce the depth of focus. So if they are higher order aberration, you use the routine lenses, patient can have the near vision. And some of the patients may have 6/4, 6/3, a supranormal vision, they can see, can read perfectly all right with the monofocal lenses. So we know that what we want, but you cannot decide because there are many formulas, every formula gives a different, and there are many other factors. So we need to understand the biometry, how to go about it once we have decided what we want. So we need to use the lens you feed and take all the formulas, whatever available. And tear chamber depth is very, very crucial in deciding the IOL power. Reason being, like if you see when you put on a AC IOL, you need 15 diopter. When you put on a PC IOL for the same eye, you need 20 diopter. So that means the lens when it comes closer to the cornea is far more effective than when it is away from the cornea. That means if the patient's anterior chamber depth is more, you need more power for the same effect. If the anterior chamber depth is less, you need less power for the same effect. And refraction, whenever the patient has got refractive error, also has to be taken into consideration whether biometry is matching with the refraction or not. And astigmatism has to be handled, we'll talk about it. So in my, to go to the formula is of course Barrett, but all the other formulas are there, SRKT, Holiday, Hoffer-Q, Hill RBF and Haggis, so that you can analyze. Just 1 minute more. So when I use the synergy lens, all the lenses, half a diopter is equivalent to 0.33 at refractive error. So synergy lens, I will choose around anything between minus 0.10 to plus 0.23. I will not go beyond minus 10. I'll rather have little plus. Symphony, I will choose more than minus 0.25 in the first eye. That means anything between minus 0.25 to minus 0.58. I will not like to have less than that. Monofocal distance, if patient wants, then I'll take the first minus. If he wants little bit of more intermediate, then I'll take the second minus. So depending upon the patient's requirement, and if the premium monofocal, if patient wants a very good distance vision, use them like a synergy. If patient wants an intermediate vision, then use them like a symphony. On the other hand, then the second eye is to be decided after 1 week of the first eye surgery, depending upon the patient's need and satisfaction. So this is one case where there is no confusion in the biometry. All the formulas are giving 19, no confusion, whatever lens you are using, decide. And this is the patient which has got AC depth, which is 4.05 millimeter, very deep AC. So I rather use higher than the highest power to achieve that effect. I will not undercorrect, rather I will use 0.2 minus 0.25 more in these cases. This is a patient where there is the biometry you see on a different formula is varying from 12, 13, 14. There are 13 which is matching on the 2, and anterior chamber depth is less. So if the anterior chamber depth was more, I would have gone for the 14, but anterior chamber depth is less, so I'll go for the 13 diopter in this patient. So first negative, same way, because the time is over. So suppose you get a patient who is getting a 21. If he's using specs minus 2, I'll go for 21, 20.55, but if he's using plus 1 or plus 2, I'd rather go for 21.5. Little on the higher side if patient is hyperopic. In a case of myopia, high myopia, and this you will see that most of the formulas are giving 2, minus 1.5, 2.5. But this myopic patient will be happy being little on the myopic side. I will use minus 4, which will give around minus 0.67, minus 1, instead of going for that. So the astigmatism, monofocal IOL, astigmatism, I will target a spherical equivalent of minus 0.5 or minus 0.75 if I am leaving the astigmatism uncorrected of minus 1 to 2 diopter. But I am using the multifocal IOL, then I will correct the astigmatism up to 0.75 diopter, because the multifocal IOL cause loss of contrast, and so does the astigmatism. So we don't want to compound them. So in the nutshell, that patients' needs and budgets and psychology and profession have to be kept in mind. Any ocular pathology, EDOF lenses to be avoided. Pupil size and astigmatism play an important role. Target refraction depends upon the type of IOL and the first eye what you got, and use that as your guide. Biometric chart with different formulas need to be analyzed. AC depth and refraction to be taken into consideration. Be ready for explant or laser correction if they are refractive surprises. Thank you very much, sir.
Thank you, Hermes. Only 2 questions for this one. One is, the patients are operated for the, you can say, monofocal in one eye. And that patient came to clinic and he says that he want near vision also in the other eye. Which lens he will choice?
See, if the patient has got a strong feeling for the spectacle independence, I'll put multifocal IOL, because the modern multifocal IOLs have got far less glare and halos and a loss of contrast. With the very clear understanding, with all my patients I put multifocal. I tell them there's absolutely nothing to worry. If you are not happy, explant will be done free of cost. So that is, if patient by any chance is unhappy, so explant is very easy these days, so I think I explant and put the monofocal lens.
Okay, so you go for the multifocal, or
Yeah.
you go for the bifocal?
I mean, EDOF lenses, I'm depending upon if he's interested only in a mobile, then I think Symphony and VVT type of lenses are work very well, because they have got, like VVT, out of all these lenses, I find VVT has got the least glare as compared to the Synergy Symphony. But if patient wants a very good near vision and a reading vision, then Synergy is the better choice.
The patient is having the this Indian multifocal in the other eye, and now he is rich, he want an important multifocal. How will you balance?
So if patient is unhappy with the vision, so we need to analyze whether, because I don't think the Indian and the international multifocal really make much of a difference, because the technology is the same. So we need to analyze whether he is unhappy because of the multifocality of the lens itself, or because he has not paid and he feels the cheap lens has been put, then of course you can go for synergy lenses or any other lens for that matter. But if patient may be having problem because of the multifocality of the lens itself. I explanted my own patient, कि डॉक्टर साहब आपने क्या कर दिया मेरी आँख में, मैं तो भगवान की आरती नहीं कर पा रही हूँ, वो पूजा करती थी उसको इतने सारे देखते थे. So you need to analyze the patients, and some of the patients may be unhappy for the residual refractive error. Like I put on a multifocal IOL and the patient was -1 with -1 cylinder, it was VT toric. So if the spherical equivalent is near 0, the rotation of the IOL will work. But the spherical equivalent is say -1, -1.5, then repositioning of the IOL has got no role. Rather you go for a laser correction than doing the repositioning.
Thank you, Harbans. The second thing is when I was there in JJ, when they will ask more than 3 questions to me, I will always tell them to go to Dr. K.K. Mehta, he is a good surgeon. But now as I am in the practice, and when they ask me 5 questions, then I increase their price by 50,000. So that they are going to ask me so many questions. Since morning to evening, I am just answering them on the WhatsApp. So such type of patients, when they are coming to us, they reduce our age. So it is better that they should be told properly and they will not trouble us.
So I think if the best thing is that if you do not have anybody who is not having a counselor should have a counselor, because that increases workload to a large extent. Even if there is a doctor, VIP, ophthalmologist, anybody, another doctor lady came absolutely prepared कि मेरे को यही multifocal, मैंने कहा no. You will have to go to the counselor, listen to her, and then come back to me. I'll talk to you afterwards. So that reduces your table time. Otherwise, suddenly they will keep on asking one question after the another question. So even if it is a good friend, he asks you take a decision, I will not take a decision. First you go and listen whole story and then come back to me.
Harbans, you mentioned EDOF lenses. Now, do you consider only VVT as an EDOF lens, or do you consider IHANS and Impress and other lenses also as
See,
EDOF
the
lenses?
IHANS lenses we call it a premium monofocal actually. But anything which gives more than 1.25 diopter of a continuous vision range, we can call them EDOF lenses. These are very gray zones. So even all the lenses are to some extent EDOF if you see.
Yeah.
And so all the lenses and all the EDOF lenses, what they call a continuous range, have got some peaks. They are not that the continuous range is same. Like if you see this synergy will have a 33 centimeter, and it is a multiplication because the optics is like, say, I was always wondering why the pan optics has got 60 centimeter. Because after 33, then after 40 centimeter should be 80, 160 because the refraction is such. So if you are getting first focus at 33, second will be 66, after that will be 132. But then I tried to find out, and the pan optics at the bullseye at the actually 60 centimeter. That's the reason it gives a 40, 60 and 80. But it is not because of the diffractive optics, it is giving 60 centimeter. So the lenses you have got to choose accordingly, but all these lenses have got, they call it EDOF, but there are 2 peaks over there. In between they are not 0, but there is some.
Now, what addition do you require in a VVT lens, or what addition would you require for reading in, supposing an IHANS or an Impress lens? Is that price, is it worth that price difference of about 20 to 30,000 rupees?
See, I think the price should not come into the picture at all, and we underestimate the paying power of the patient actually.
No, I mean, but is there a great advantage, because there also you
Yes.
you need addition of 1.5.
You put on an Armani suit, I don't think it gives you any advantage whatsoever. It is on your routine suit what you put on, but still people go for that, and many people feel happy only when they spend the money. But at the same time, definitely there is advantage of this technology. There is no doubt about it. I mean, if you see the near vision comfort level they have got is definitely more than that. And many of them have got a very good vision, and in spite of the monofocal, but definitely the multifocal and EDOF lenses will have a very good vision. And sometimes some patients, you can say 5% of the patients do consume your more table time post-operatively as compared to the other patients, and that you have got to be prepared for if you are going for a big time multifocal practice.
Thank you, Harbans. Thank you very much for answering all the questions as a CA president and expert. Now I will call upon Dr. Tushar Agarwal. He is going to speak to us on the enhanced monofocal, which can be used for the astigmatism. And before he takes over, the experience of the eye surgeon, operating the eye surgeon. Those patients, eye surgeons whose age is more than 70, if they are coming to me, they ask for me monofocal IOL. They never ask me for any other IOL. Those who come at the age more than 60, they always say go for the bifocal IOL. And less than 60, I operated only 3, they come for the multifocal IOL. So I think the age also is matters when the ophthalmologists are getting operated. So Tushar.
Yes, sir. Thank you very much, sir. Actually, this talk will actually feel like extension or continuation of Dr. Harbanslal's talk. So I think some of the points which were raised in the last by Dr. Noshi Shroff, I think I might be able to put some clarification on that. Now, okay, slides.
Slide नहीं move हो रहा है. Slide. Ah, okay.
So there is no financial interest in the presentation. Now, why we are bothered about astigmatism is that about 50% of patients present with more than one diopter of astigmatism, and around another 25% fall in the range of 1 to 1.5 diopters of astigmatism. And as cataract surgery itself has become partly a refractive surgery, this has become more important to treat at the time of cataract surgery. And it's important because up to around 0.5 diopters of astigmatism, it has minimal to no effect on the visual acuity of the patient. Most patients will have 20/20 visual acuity. However, as the astigmatism inches up higher, even a 0.25 jump from there starts to play on the UCVA, and 1.5 diopters or more will have a significant impact on the uncorrected distance visual acuity. And this is why we now try to deal with astigmatism along with cataract surgery. So there are various modalities in vogue. Incisional modification, it was relevant when the incision sizes were more than 2.8 millimeters. At that time, an axis phaco could deal with low degrees of astigmatism, but with now 2.2 incisions, which are astigmatically neutral, that axis phaco doesn't work. Then you have techniques like arcuate keratotomy and LRIs, especially now with femtosecond. These are a good option to treat, again, low to moderate degrees of astigmatism, but the reliability is not as great as toric IOLs, which are now the gold standard or the standard of care for managing any type of astigmatism with cataract surgery. Another choice is a staged corneal excimer procedure. It is very effective in treating any kind of astigmatism post-operatively, and it will also take care of any refractive surprise or even surgically induced astigmatism. But of course, it requires the second surgery, which most of the people won't like in cataract surgery. A couple of words about toric IOLs. They are very predictable now in correcting very high degrees of astigmatism also. They are very reliable. There are no additional incisions required. However, they do induce extra steps in the operative workflow. You need extra machines for preoperative workup, intraoperative use as well. Then there is always a risk of rotational instability, especially in the initial curve. Some patients may require rotation of the lens in the postoperative period. Then there is a logistical challenge also, that some patients with very small pupils, patients with BPH, corneal opacities, you may not be able to accurately place the toric IOLs, and surgeons may be wary of putting toric IOLs in such patients. So the current talk stems from a couple of papers which were published around 3 years back, which presented the results of the enhanced monofocal lenses or the EDOF lenses. These terms are used interchangeably, but Vivity, for example, is formally called an EDOF lens. Eyehance comes under the category of a premium monofocal, not an EDOF, because as Dr. Lal pointed out, the range is slightly less than Vivity. So, and a corollary of these studies was that they found that they postulated that somehow the astigmatic tolerance was slightly higher than monofocal lenses. And we hypothesized that the reason could be that how these lenses are made to function. Monofocal lenses have a single plane of focus. The so-called multifocal lenses like Restore in the past, they were actually bifocal lenses, which had two planes of focus. But the EDOF lenses or the enhanced monofocal lenses have a slightly elongated plane of focus. And this is how they work. So this again, coming to our old textbook knowledge of Sturm's conoid and how astigmatism affects vision. So if you have a monofocal lens, you will need a pinpoint focus at a particular plane to achieve 20/20 vision. But how the EDOF lenses work is that this plane is actually enlarged in both directions, and that is why you achieve a slightly extended range of vision with these lenses. And this was the hypothesis that we wanted to test, that whether this can actually also accommodate for the slight amount of refractive error induced by low degrees of myopia. So we studied a group of patients, 19 each, in which they had 0.75 to 1.5 diopters of myopia. We selected this range, which was the starting range for where we start putting toric lenses. Below this, we normally avoid toric lenses. And both sets of patients underwent bilateral cataract surgery sequential, and in one group we used an enhanced monofocal lens, and the other an equivalent standard monofocal lens. So what we found was, so we analyzed the results both binocularly and uniocularly. I'll explain the reason a little later. So in terms of binocular UCVA, the results were similar. The enhanced group had slightly better vision post-operatively at all follow-ups, but all of them did not reach any significance at any point. They did, however, show a significantly higher, better unaided near visual acuity. And this is the curve, I think, which Dr. Harbanslal was also referring to, that we found that there was a significantly better defocus curve. So you will find that up to point, so what this lens, just to simplify how to interpret this, is that an enhanced monofocal lens will allow you a slightly, it will tolerate a slightly higher degree of spherical equivalent in the post-operative period. And this actually allows for the higher range of vision to develop. And this was found to be significantly higher, which we expected in the post-operative period. The contrast sensitivity was also higher in the enhanced monofocal group. Now, we also tried to differentiate between patients with the on the basis of just not on the logmar visual acuity, but on the basis of how many lines of vision which they have, and this is where the two lenses separated in terms of the results. Almost 50% of the patients with the enhanced monofocal lenses had 6/9 or better vision binocularly, whereas only about 10% of patients with monofocal lenses had this vision. Then we separated the groups further into two subgroups. The first group which we took was only up to 1 diopter of astigmatism, and the second was 1 to 1.5 diopters. And again, here we found that almost 85% of the patients had 6/6 or better vision when they were implanted with an enhanced monofocal lens, whereas only about half of the patients with a standard monofocal lens had 6/6 or better vision. In the higher astigmatism group, you will find that the results became similar, almost similar in both groups, where we found only 70% of patients had 6/6 or better vision, as compared to 42% in the standard monofocal group. So to summarize the results, at 3 months, binocular visual acuity in the group ranging from 0.75 to 1.5 diopters, there was no statistical difference. However, they did show a better unaided near vision, better intermediate vision, and better higher contrast sensitivity. And when you talk about the subgroup of 0.75 to 1 diopters, almost 85% patients achieve 6/6 or better vision without the need for any toric lenses. So I'll conclude my talk here. Toric lenses remain the standard of care for managing any degrees of astigmatism along with cataract surgery. However, enhanced monofocal lenses seem to be a viable option, especially in patients where the astigmatism is 0.75 to, so that's the exact narrow zone where these lenses may be helpful, because less than 0.5 we as such do not use any toric lenses. We start to use toric lenses once the astigmatism goes beyond 0.5. So in the range of 0.5 to 1 diopter lens, these lenses seem to provide a very good uncorrected distant visual acuity. However, these results need further validation. This study was done at the time when IHANS was available and the IHANS Toric hadn't come. Now the IHANS Toric. So the ideal comparison now, which I think we would plan, is a head-to-head comparison between IHANS Toric and IHANS in these patients with the low degrees of astigmatism. Thank you.
Tushar, thank you. It was a self-explanatory, and so that we will not take question answers, we are getting late. So Dr. Mal Fernandez is there. Dr. Fernandez, okay, please. So she is going to speak to us on the pediatric cataract, what to do and what not to do. Dr. Fernandez. Now we can take Vanhati till before that. Vanhati, you come here and start your presentation. I will miss up.
afterwards ना इनको टाइम लगेगा तो you can take question.
नहीं क्वेश्चंस नहीं लेना, उसको करने दो, शुरू कर, लेट हो रहा है, ठीक है, ठीक है.
Can be ready, Vanati can be ready, yes.
ठीक है. हाँ.
Tushar, I want to ask a question to Tushar that what is the experience of yours with any other EDOF lens compared with the enhanced monofocal lens?
So as we were speaking, so we do use Vivity also, but as suspected or as you pointed out, there is not much of a difference in terms of the near ad required. So both lenses, in most patients you will find the patients reach about N8 vision. And they do require an ad of 1 to 1.5. Though I haven't formally studied the two lenses in terms of the near ad required, but my sense is that both require 1 to 1.5 diopters of near ad for reading fine print. So
Any more dysphotopsia with the VVT lens, because that's got a bump in the center, whereas these enhanced monofocals are almost have a aspheric surface, anterior surface, and therefore no bump or no this thing. So does that cause any dysphotopsia?
Sir, my experience with the two lenses, so it's almost about a 75-25 ratio, 75 in about 75% IHANS and 25% Rivety. But I haven't seen any IHANS absolutely. But so the weight of experience is 3 times that in Rivety. But I haven't seen any photopic phenomenon with the Vivity as well.
Yeah, so thank you very much. I'd like to thank all the dignitaries on the dais and the AIOS as well as the APOC, the Andhra Pradesh State Ophthalmic Society, for inviting me. I have no financial disclosures. I have changed the topic slightly because Dr. Lahani so eloquently described pediatric cataract surgery. So my talk is going to be on IOL implantation in infants, to do or not to do. So when you look at a child and you're planning a cataract surgery in a child, there are certain issues that we have to consider. One is the fact that it's a much smaller eye. There tends to be a significant amount of inflammation postoperatively. Calculation of the IOL power is more challenging because the IOL power formulae that we have, they're actually for adults and not for children. And so the age of the age at which we're doing the surgery also matters, because the eyeball is growing and then you tend to have refractive surprises. They tend to have PCO. There's a lot of proliferation onto the anterior hyaloid face, and they tend to get PCO. They also tend to develop glaucoma, and they develop amblyopia, which is the main reason why we want to do the surgery sooner rather than later. So the surgery per se, I think I'm not going to go through all the details. Dr. Lahani has described it in very well in his previous talk. So what we have to understand is that the capsule is very elastic, and we need to make sure that the rhexis covers the optic. It should be 5 millimeters, and you do it with the help of a rhexis forceps. And the other thing that we have to ensure is that you make a PPC which is a little smaller, because you need to have a gap between the anterior capsule and the posterior capsule enough to accommodate the intraocular lens. When you're putting it inside, it doesn't fall into the vitreous cavity. And we always land up suturing. So I'm not going to cover anything about the surgery per se. But when you're operating a child, and previously we used to leave these infants aphakic. They used to wear aphakic spectacles. You realize that these are bulky glasses. Sometimes the glass actually touches the eyelashes of the child, and it becomes a little problematic. They also have a constricted field. For monocular aphakia, unilateral cataracts, this is obviously not an option. So the other option for managing these infants is using contact lenses, which have been there since 1959, but the silicone contact lenses that we use are the ones that have revolutionized this, and these lenses are very useful, very easy for the mother to handle. So they're safe. We can keep changing the contact lens based on the power, and there are certain issues with respect to the maintenance as well as with the cost over time, but they do give very good outcomes, particularly if you institute amblyopia therapy simultaneously, and there is a minimal risk of infection. The intraocular lenses have been used very widely for children over 2 years of age, and their long-term safety has been established. The only thing that we're concerned about, of course, is because we put the IOL in the bag, we have to make sure that the posterior hyaloid face remains clear, the visual axis remains clear over time, which doesn't always happen. The power has to be modulated, as Dr. Lahane pointed out, to accommodate for the age of the child. So now, what do you do for infants? What do you do for somebody who's less than a year old? And the IATS that was conducted in the US actually was a multi-center trial by Scott Lambert's group, which actually started looking at a comparison of the intraocular lenses in infants. They implanted these lenses over 12 centers. It was a multi-center trial between 1 to 6 months of age. So that was an age when you thought, can we actually implant an IOL inside the eye or not? But they did a study where they looked at the IOL with glasses versus contact lenses. Now, what they found was very important, because they found that there was no difference in the vision at 1 year, not much difference at 4 or 5 years either, and there were several papers that came out from the IATS study. But they noticed that there was an increase in the intraoperative complications in the IOL group compared to the contact lens group, because if you're putting an IOL in the bag, then there are issues. There's iris prolapse intraoperatively, there's a larger incision, you have to suture that. Whereas if you're leaving the child aphakic, you don't have to do that. There were more adverse events in the IOL group with lens epithelial cell proliferation, membranes, correctopia, compared to the contact lens group. They landed up obviously doing more surgeries in the IOL group versus this. And obviously, if you're going to do additional surgeries, you're going to pay, the parents have to incur a greater expense. So there's an increase in the cost involved. And the younger the child you operate, there's a higher risk of glaucoma, which is something that we have to be very aware of. Simultaneously, there was a study conducted in the UK where they looked at IOLs in children under 2, but they took up to the age of 2, and what they found was that bilateral cataracts, younger age group had a high risk of glaucoma, and those who had microphthalmos, so unilateral cataracts with microphthalmos, there was a higher risk of glaucoma. So one has to understand that if you're going to put an IOL in a child, and they are very young, so between 1 to 6 months of age, then the chance of glaucoma is much higher, which means that the follow-up in the postoperative period has to take this into consideration, and we have to keep checking the intraocular power. And we have to keep checking the refraction, make sure that you're changing the glass power based on that, and keep checking the intraocular pressures, because they may develop glaucoma, which we may miss. And if there's a shift in the refraction, more of a myopic shift, increase in the axial length of the eyeball, increase in the white to white, these are all the signs that we have to keep looking for, which will give us a clue that the pressure is on the higher side, and control that appropriately. They may require additional surgeries, the anti-glaucoma medications that we instituted, and we have to keep a track of these kids. So it should not be that we do a fantastic cataract surgery and then lose vision because of glaucoma that sets in. So in summary, based on the data that we have, that I've just presented to you, the intraocular lens implantation does have adverse events, does land up having additional surgeries that need to be done postoperatively. So for very young infants, this may not be the best way to go. Probably for kids above 6 months, I think an intraocular lens can be implanted. For the ones less than 6 months, we could probably leave them aphakic. And additional surgeries may have to be done, particularly if you have to clear up the visual axis over time. The risk of the glaucoma that I mentioned is definitely there, and therefore it's important to keep these kids under very close follow-up with regular examination under anesthesia, measurement of intraocular pressure. We could use the eye care tonometer to measure pressures, but it's important to subject them to anesthesia to get a more accurate assessment. Thank you very much for your patient hearing.
Thank you, Dr. Mal. I think you have covered very well. What she says, it is 1 to 6, it is difficult because you get the complications. But what is discussed now today is, after 6 months, when the axial length of the patient is more than 17 millimeter, in such cases, you can go for the IOL.
Yeah.
So that not before 6 months, but after 6 months, where the contact lenses is difficult, the patient is from the rural area.
Yes.
In this situation, when it is a 17, you can go ahead, and now I will thank you very much.
Yeah.
And now I will call Vanati. I will mishaps. So Vanati, as you know, she is a editor, and now she is going to speak to us on the I will miss up. Vanati.
Thank you, sir. So I think I'll just shift gears to a lighter note from all the heavy optics and calculations we heard on IOLs here, and no financial interest. I'm just going to give you a series of common occurrences in cataract surgery which we all of us do face, and it does become worrisome at times when it gets too complicated here. I thank Dr. Nopur and my senior residents for putting together all these events which happen during our cataract surgeries here. So you have this, which is very commonly you see when you have not wetted your lens well, when you're loading it onto your injector, you have this sticky haptics situation here, when the haptics are handshaking for too long than desired here. And here you have the next scenario when the following haptics get stuck in your wound because of wrongly followed insertion technique here. Here again, especially when you're doing topical surgeries and the patient has looked away from you when you're inserting your lenses, this is a problem which can occur. And if more than 2/3 of your lens is gone in, then you're lucky and you can quietly tease your lens in. But if it's less than 1/3, then you would be in a problem when you're trying to manipulate the lens inside or outside here. So one needs to be aware and be careful of these scenarios, especially when you're doing topical surgeries here. So pushing these lenses in could cause an inadvertent jerk into the anterior chamber and damaging the capsular bag in such scenarios here. And remember, there would not be space for you to enlarge your tunnels here. So this should be a well thought out step whenever you're doing when you're doing a cataract surgery here, because you can land up in more problems because of improper insertions. Here you have when IOLs, the haptics gets broken because of a wrong loading scenario, because of a manufacturer defect here. And when it is broken here and the lens tends to be unstable, we're putting up a broken haptic IOL here, it's always better not to put a broken lens inside here. And one has to then go back, and it becomes more complicated removing it rather than the primary surgery itself here. Here you have yet another scenario here when the lens has gone in, it's broken, and you find you have to now remove it and replace it with another IOL. So the IOL scaffold technique works well when you have to do an IOL replacement, or you have to do a refractive exchange of IOLs. This is a technique which would really help you out, that you do the removal of the lens under the scaffold of the lens which has to be replaced and put in. So that keeps your bag intact and decreases your damage to your posterior capsule here. Again, yet another with the preloaded lenses here. Remember, is trying to do a wound-assisted insertion of the IOL again, the surgeon here, and struggling to put it in and send it inside here. So if your lens has already come out before insertion, it's not a good way. The lens has touched a lot of your ocular surface, and then you're trying to insert it. That's not a scenario which you would like to do. So such cases, go back and reload your lenses again and put it in, rather than struggling again and again in inserting when your loading and your insertions have not been as optimal as it has to, as desired in these cases here. So all these would go a long way in preventing introduction of infections and complicating your otherwise uncomplicated phacosurgeries here. Again, here this is when the bag has not been stable here, so it's being followed with a CTR insertion as well here. So this is just a compilation of the different types of problems one you can see, and this again is not something which we would not have seen. The patient becomes uncooperative, it sneezes, and the whole eye is moved out of your field here, and you're lucky if you did not have any problems in such a scenario here. So it's always good to assess your patients preoperatively, especially if you're doing topical surgeries here, and anticipate and also counsel your patients adequately on what they need to expect when they are on the table and in the theater, so that you can avoid such kind of inadvertent or avoidable problems in such scenarios here. So a more cooperative patient is a better outcome and lesser surgical time here, and no complications as well. So that's another scenario here. Then yet again, when your IOL has been inserted upside down because of improper loading and it's not been recognized when it's being putting in here, then you'll probably have to rotate it down, or you can use a double Larsinski technique to rotate it here. So a similar scenario, and this is quite common when you're putting in multi-piece lenses, the way you'll have to rotate your wrist to get the leading haptic in correctly without damaging the other ocular structures, the bag and the iris, again is something which is it's learned well, and so that it leads you to an uncomplicated scenario and eases the way you're going to insert the multi-piece lenses in the bag of such patients here. I think I'll stop here, and thank you for your patience.
I think Vanati, you have covered each and everything in MISAP, and now the Partha, I am sorry, but our hall was given late to us, so I invite Partha. Only thing is the hydrophobic lenses, when the haptics are not opening, don't keep the lenses inside the OT where the temperature is very less. Keep the lenses outside the OT so that the temperature is good and the lenses can open. So thank you very much, and Partha here. Come Partha. Thank you, Vanati. And thank you, Tushar. Thank you, sir, and thank you, Ragini. Thank you very much. Thank you. Sir Absant, thank you, audience also. You sat on Sunday also. Thank you very much. Photo wala, come here. Those who were the speakers, those who are there, they can come. And photographer is there?
Yes, yes.
Huh.